My name is Roseanna Means, and I'm a physician on the attending staff at the Brigham. And I'm now a member of the Women's Division, and I practice at the Fish Center for Women's Health here at 850 Boylston Street.
Wonderful. You graduated from Tufts Medical School in the early 1980s and then trained in internal medicine at the Brigham. What factors in your early life before and as a physician led to your dedication to helping homeless women?
Oh, many things. So I am what they call a child of the 60s. I was somebody who spent some of my time in high school and college demonstrating against the Vietnam War and wanting to give back to society. I was very much influenced by President Kennedy and Bobby Kennedy and Martin Luther King Jr. When I finished high school, I spent a summer under the auspices of the American Friends Service Committee working on a farm in Appalachia. And really all my life I wanted to do something that was going to be meaningful and involve social change. As a resident at the Brigham, I was given the opportunity to go abroad for 3 months with the International Rescue Committee and help Cambodian refugees after the Vietnam War. They were in refugee camps along the Thai border. And Marshall Wolf very generously let me go, and I cobbled together elective time and some medical ward time and vacation time and spent 3 months living in a village in Thailand working with Cambodian refugees. And it was probably a life-defining moment where I saw that you need to carry your doctor-patient relationship inside you. It's great to have a really fancy hospital with lots of tests and lots of fancy things that you can do, but the relationship that you build with people matters the most. And more importantly, showing up matters. The fact that myself and all the other people from the NGOs around the world had showed up 10,000 miles away from our comfort zone meant a lot to the people that we were taking care of. And when I came back, I was really impressed about the impact of that experience in my life, and thought, maybe I won't do that cardiology fellowship that I had signed up for. After all, maybe I will go into general medicine, which is what I decided to do. And after I had my 3 sons, I was raising them in a wealthy suburb of Boston, Wellesley. It was a very white, upper middle class cultural existence for my children, and I thought, I just want them to see that this is not how the world works. And maybe I could give them a life lesson that would show them that life is a little bit different other places in the world, and also put into practice some of the things I've been thinking about taking care of disenfranchised populations. So when my boys were 6, 9, and 11, we arranged to take a year off, and we lived in Costa Rica for a year. And arranging that year off meant closing my continuity practice and finding a position where I could get away for a year. And I found that position at Mass General Hospital in the walk-in unit. And many of the walk-in patients I saw were homeless people. And that's kind of where it all clicked. You know, people who were literally like refugees here in Boston. They really had lost everything, didn't have a lot of things to hold them down, didn't have a big support system. And it just totally resonated with me. So I I worked at Mass General and worked with the homeless there until we went to Costa Rica, and then I worked with them until when I came back. And that was under the auspices of the Boston Healthcare for the Homeless program. Mm-hmm. So that's when I decided to include taking care of homeless people alongside my doing regular primary care. I was still doing a primary care practice in the community, but I was really drawn towards the homeless population. After about 8 years at Healthcare for the Homeless, I decided that I wanted to go out on my own and do something for women. The women are a very different population. It's not a one-size-fits-all for homelessness. A lot of men have different issues. They come to homelessness differently. They have a different kind of biology than the women do that brings them into the healthcare system. And what I wanted to do was find some way of providing immediate access to women who are homeless that didn't involve a lot of bureaucracy and didn't place a lot of expectations on them that they couldn't meet, that also felt safe, and that put them directly in line with women physicians. So that's how Women of Means was born about 13 years ago.
And what proportion of your time now do you spend with Women of Means as opposed to your practice here at the Brigham?
Well, Women Means is my full-time job.
It is.
I am the CEO, the founder, the president, the executive director, and the chief medical officer of Women Means. My Brigham practice is my half-time job.
So it's 1.5 times.
I work extremely hard. It's a very full week. Virtually, I'm basically doing something every day of the week.
Let's talk a bit about the Women of Means, a little more detail. You've told us why and how it was founded for you. Let me ask you sort of to define what its purpose is and how successful it has been. That's mostly it.
The purpose of Women Means is the mission statement is to provide quality health care, education, and advocacy to women who are poor, homeless, or marginally housed. And we do that through a team of volunteer doctors and part-time paid nurse case managers. We have gone to as many as 12 women and family shelters here in the metropolitan Boston area. We're now at 7 shelters. We do about 10,000 visits a year, all free. We provide everything from walk-in, what I call drive-by care, just handing out some cough drops or some Tylenol, to very intensive physical exams, post-assault counseling, detox referrals. We have done a lot of cancer diagnosis. This is a population that is much higher prevalence of breast cancer. We've made a lot of breast cancer diagnosis in this population and gotten women to care. We provide volunteers who take them to their medical appointments. And when people have something as extensive as something like breast cancer, we take them to every single appointment. Surgery, radiation, chemotherapy. We help them find housing. We do a lot of counseling. Our physicians come from a variety of specialties, including psychiatry, dermatology, cardiology, emergency medicine, family medicine, pediatrics. We are on site 5 days a week during the week. And we're available by pager or email or text message, any other way in between. We can write prescriptions for the women if they need them. And we also have a very robust training program for medical students, Harvard medical students, as well as medical residents from all the Boston teaching hospitals. We oversee about 100 students and residents a year, including nursing students from Regis College and Mass General Hospital. Our annual budget is about $700,000. It all comes from grants and donations. It's been pretty flat for the last few years because of the recession. And yet the doctors donate about $500,000 a year in professional services. We leverage that kind of gift of care to about $15 million in savings for the Commonwealth in keeping the women out of emergency rooms, out of inpatient stays, out of bounce back. So the return on investment is huge, in terms of what people get when they donate to Women in Means.
Yes.
We have never billed for our services. We are not a fee-for-service model. So much of what we do is working with women who have mental illness and who have trust issues. Nearly 100% of the women we take care of have been assaulted in some way. And so a lot of what we do is building up steps of trust, and that takes time. It can take literally years to build up a relationship with somebody who's lost trust. And so back in the beginning, we thought about, are we going to adopt a model where we would bill Medicaid for our services? You can't bill for sitting on the sidewalk with a cup of coffee with somebody with schizophrenia, trying to convince them to sleep inside instead of outside during the wintertime. There's just no billing code for that. Fortunately, we've gotten a lot of recognition for this work. I was named as a Robert Wood Johnson Community Health Leader in 2010. I was a CNN hero in 2011. And we've presented our model nationally and, in fact, in Poland as well, internationally as well. What we have been able to do in the last few years is focus a lot of our intensive case management on the elderly homeless women. We did a study a few years ago. Nearly 10% of the homeless women in Boston are over 70 years old. And so we started a program, a multi-agency collaborative, where we were able to provide clinical care and case management, intensive case management, housing assistance, and so forth for these women who were elderly and getting older in the shelter system. That was very successful. And what we learned was the collection of services that we provide, everything from soup to nuts, from coming in for the cough drops and the Tylenol, to housing appointments, to primary care appointments, to assisting getting people to appointments, making phone calls, housing arrangements, all of that stuff. All of those things are like a home for the women. It is what we call a medical home, but without walls.
Yes.
So in parallel with the national discussion which is going on now about patient-centered medical homes in places like the Brigham and the places like the Fish Center, where you have the clinical staff and the paraclinical staff helping out, reaching out to people. In the world of homelessness, the women don't have phones, they don't have email, they don't have ways to be communicated with, but they have a lot of the same medical problems. Yes. So we become the support system, the hub of the communication network. We replace what they would have if they were housed and had insurance. We're the neighbor, we're the best friend, we're the church member, we're the daughter or the mother or whoever it is that would help them navigate through the morass of the healthcare system. We become all that for them. And so in the last year, we've been able to describe this, the benefit of this medical home without walls model to people who are involved in health policy here in Massachusetts. And in fact, in 2013, we are going to be executing a pilot program in collaboration and partnership with Boston Medical Center. And in exchange for the access to the Women and Means infrastructure and the trust and the experiences and the relationships that we have built up, we are going to contract with an ACO to get a global payment for those services in taking care of a pilot cohort of 50 women who are homeless, who are 65 and older, what they call dual eligibles. So for us, that's an exciting turning point. We will not, of course, turn our back on the other 2,000 women that we're taking care of that we see in the shelters, but these 50 women will have an opportunity to not only get the walk-in urgent acute care that we've been giving them all along, they will have an opportunity to have Women and Means be involved in their primary care as well.
Yes. And
we'll close that final last gap for these older, vulnerable women. And the fact that we can get some sustainable funding for that will allow us, I think, more future success.
Yes. Has the Brigham been supportive and helpful to you and your organization?
Absolutely. The Brigham has been wonderful to Women and Means. We have gotten grant funding from the Brigham and Women's Hospital in collaboration with partners. Mm-hmm. And my colleagues, my division, Paula Johnson, who's my chief, is exceptionally supportive of what I do in the community and the model, the kind of role model that I want to be for future generations of doctors. In fact, Dr. Johnson is on my advisory board. But it's really important that people, my colleagues here, my peers here, and again the future generations of medical students here, see what the power of volunteerism and how you can apply the striving for excellence, which is the hallmark of the Brigham. That's why I've stayed here for 31 years. The Brigham has been my clinical medical professional home for over 3 decades.
Yes.
And very loyal to the Brigham and feel very grateful to continue to be here.
Mm. Have you, your organization is analogous in many ways with Paul Farmer's Partners in Health. Have you thought about at all generalizing it to other states or other communities?
Yes, as a matter of fact, we would love to replicate this model. And where we are on the sort of the spectrum is, we've certainly demonstrated our effectiveness. The pilot will give us good metrics to support that.
Yes. And
then going forward, we would like to look for some social impact investing to support the work so that we can replicate it in other communities. We do feel that we are an adjunct to the kind of services that are already there. When I left healthcare for the homeless to start Women and Means, it was not to duplicate what they were doing. They have a wonderful, very, very robust and program that provides a whole variety of services. Wraparound services is the word I'm looking for. We target women.
Yes.
Ours is women, especially elderly women. And it's just a different biology and a different set of needs that the women have that we're very, very good at doing. And we just believe that in other communities around the country, there are other kind of agencies and organizations that can work together, as we have here in Boston, to target this niche population.
Yes. Let me ask you finally a question or two about the future of you and your Women of Means and medicine in general. What do you anticipate for the future? I think you've already alluded to this, but if there's anything else you'd like to add to that.
Well, the other part of what we're doing in the future is we're looking at the components of what constitutes the healthcare delivery model. And there's been a lot of discussion about where is primary care coming from. I've been a primary care doctor from the very beginning.
Yes.
And now there's a lot, the Massachusetts legislature has just passed the opportunity for physician assistants to do primary care, which is wonderful. They're become, expanders of the role of primary care. What we are doing in Women and Means is we are deconstructing primary care in another way. We are using multiple specialists in delivery of care, but we're also using lay people as volunteers who can help take people to appointments. Again, who will become the neighbor, the friend, the church member that they don't have. And when we do our pilot program in 2013, we're also going to be introducing a community health worker to our model. Community health workers, the concept of community health workers goes way back to the barefoot doctors in China over 50 years ago. Somebody in the community who knows that community very well, who speaks the language of that community, and can assist in certain ways in terms of medical education or nutrition education or just explaining things, making phone calls, making connections. And as you are well aware, in the Hispanic community, the promotores is the word that they use for that, people who are part of the culture and are able to speak for the culture. And we find that that's going to be something really important for expanding our reach in the homeless community, just simply because the women are all over the place. It's a mobile, transient population, very hard to reach, and you just have to have people embedded in that community to make it work. So we like being part of this national discussion. We like the idea of looking at how medical care is being delivered, who is actually doing the delivery of it, how are the roles being used, and how can we be smarter about using people in ways that not only provide more personal care and more literally patient-centered care, but also in a way that's cost savings for the whole community.
It seems to me that your organization is one that may be looked at as a great example of a means for saving money in the medical care system, which of course is going to become an even more important factor in medical care in the next few years. Do you think that the constraints that are imposed on the hospital, on the practice in general, will affect Women of Means, or will you continue to flourish?
Are you talking about the constraints on all hospitals or on the Brigham? I think that all hospitals are having this dialogue about who is doing what and how people's time is being used and what the roles are. I think that's a very important thing, and I do think we have to look at it from a 360-degree angle and just see how people are coming into the system, how they're using the system, and how they go out of the system. I think a lot of health takes place outside the hospital. Healthcare really is a broader subject. I mean, my population is where they wake up in the morning, where they get food, are they warm, are they safe? And I think that as hospitals learn to look at populations in terms of their vulnerabilities, they're going to have to rely on community programs like mine to reach people in a very targeted way. It's not a one-size-fits-all. It's not that you can just have a build it and they will come mentality, with the latest in technology and the most successful transplant service and the best surgeons and the best cardiologists. Not that they aren't great, but there are people out there who simply cannot read signs. They don't know how to negotiate a long hallway. They don't know how to go up in an elevator. They feel scared going to a place where they have to register and put down their personal information. And that's a lot of people with a lot of cognitive, executive, and emotional impairments that don't use the system as we now expect them to. So I think that part of the national dialogue that's going on is how do we identify those people? How do we work with them? Who best represents them? And how can we all do this together? How can we close these gaps and work together to make it more efficient and more personal and more realistic?